upcoming area where more research and clinical applications are required to implement on a daily basis, which is lacking as of now. So let's start and discuss more about card cells, what these card cells are, how to produce them, what are the fallback, what are the applications we can do with the CAR T cells. So I'll be taking you through what are the card cells, what are their targets, clinical applications, how to manufacture them, how to manufacture card cells with clinical grade. So because we have to give them to the patient, so safety and efficacy is more important. The facilities are required to establish card cells facility, the guidelines, how to step about the facility, manufacturing facilities, what are the current limitations and what are the future opportunities to implement CAR T cells therapies in a day-to-day basis, and I'll be discussing about few case studies as well. So the CAR cells is a new technology and has allowed for the production or the introduction of a high degree of tumor selectivity into adaptive cell transfer therapies. The evolution of this technology has produced a robust anti-tumor immunotherapeutic strategy that has resulted in dramatic outcomes in the liquid tumor therapies as well as the solid tumor therapies. The CAR cells targeting CD19 and CD20 for the liquid tumors or hematological malignancies have been successfully used in the treatment and produce sustained tumor regressions in a majority of the treated patients, which are unable to achieve with the current conventional therapies. These encouraging results have led to a historic, unprecedented FDA approval of CTL019, which is produced by the Novartis CAR T cell therapy for the treatment of children and young adults with relapsed or refractory cell lymphoblastic leukemias. Let us start one by one what these CAR cells and other applications. So the CAR cells is the treatment for relapsed or refractory carcinomas using patient-derived T cells which are genetically modified to target the cancer antigens on the surface of malignant T cells, and this cell therapy has shown promise in patients with leukemia, lymphoma, myeloma in different clinical settings. There are three main reasons why many healthcare providers are considering CAR cell therapy and the opportunities to provide to the patients for remissions, return and re-own. Because the complete remission with CAR cell therapies are as high as 90%, has been seen in various clinical trials for the patients with relapsed and refractory B acute. Just hold. Hello.
Hi, Dr. Mittal, just I would like to remind you that could you just F5 screen, your slides cannot appear as a presentation form.
Okay, just a minute. Now?
Yeah, now it is okay now.
Okay.
That's okay. Okay, thank you. Okay.
So why these T cells are important? So first question comes that because we are talking about CAR T cells. So why T cells? Why not B, CAR B cells or CAR NK cells or CAR DC cells? Why only cells? Why we are targeting T cells? Because the T cells are recognized host versus non-host cells to initiate an immune response. Secondly, they are the primary immune system agents which attacks the disease cells or the infection. They are used in several cell-based therapies which are not frequently as other cells are. So these T cells are involved in the transplantation of donor cells, a bone marrow transplant in which a matched cells used to replace the patient cells, which is most widely used approach, typically originate in the immune system, that is leukemia. The isolation and enrichment of patients' T cells, it is an approach considered the safest therapy which enhances the patient's own immune responses to the disease. Next is the CAR therapy, a more recent approach in which T cells are removed, genetically modified, and express a synthetic receptor against a specific cancer cells, and then the modified or genetically modified T cells are infused back into the patient's bloodstream. This therapy is effective because many cancer cells hide from the immune system and appearing to be the normal cells, thereby triggering no immune responses. Now let us see how these T cells, CAR T cells, work for the therapy. The patient-derived T cells are collected by leukapheresis, or a process which separates the white blood cells from the whole blood cells. This is usually acted by a differential centrifugation process, and subsequently the T cells are activated in vitro by stimulation with the magnetic coated beads and acts as an artificial dendritic cell. Activated T cells are then infected with the retroviral vectors to integrate the CAR genes or the modified genetic cells into the T cell genome. The CAR expressing T cells are further expanded in vitro, or these genetically modified T cells are expanded or cultured in vitro in the lab by combining the growth factors like interleukin-2 and transfused back to the patient. And to prevent the rejection of the CAR T cells by recipient's immune system, before infusing them back, a chemotherapy is provided, that is again a lymphodepletion is being performed before infusing them back to the patients. So here is a history how this CAR immunotherapy has been developed so far. And very first in the year 1998, the CD19 antigen has been identified for the leukemia cells therapy. In the year 1996, CD28 co-stimulated domain is also incorporated within this CAR T cells.
Hindistan'dan Dr. Özellikle bunlar
within these CAR T cells and so on, because now there are many generation of these CAR T cells. Evolution has been taken place. So along with the main antigen receptor, along with that, so many other co-stimulatory molecules and cytokines genes are also incorporated in the CAR T cells. Let us see how these CAR T cells have been developed and what are the targets for which the CAR T cells are available. So, in this picture, as we have seen, there are 4 generations of the CAR T cells are available now. So, very first when it developed from the monoclonal antibody. It has 3 domains. One is the ectodomain, which is antigen recognizing domain. Then the transmembrane domain and the signaling domain, which is derived from the CD3Z domain. So as the CAR T cell evolution taken place, second generation, along with the signaling domain, the co-stimulatory domains are also incorporated. In the third generation CAR T cell, 2 co-stimulatory domains are incorporated. While in fourth generation of the CAR T cells, along with the co-stimulatory domains, cytokine genes or other enzymes and other viral epitopes are also incorporated, so that later on, after CAR T cell therapy, the infections can be avoided, like CP infection, EBV infections. Those infections also can be taken care by the use of 4th generation CAR T cells. So this picture shows that how these CAR T cells, so these are the first CAR T cells have been developed. Outside it is an antigen recognition domain, and this is the signal. CD3Z is the signaling domain. When the cell enters and activity T cells are there, these CAR T cells are incubated with that, and then it enters into the cell and the tumor cells. So after in the 4th generation, which is known as fourth generation truck cells. So what is this truck cells? The truck cells are T cell redirected for universal cytokine mediated killing. So when we give this therapy, so there are toxicity issues will be there, efficacy issues will be there, some cytokine toxicity will be there, some infections will be there. So when we incorporate these cytokines genes into the along with the co-stimulatory domains, so those things will be taken care. So now let us see, there are several CD markers for along with the different kind of hematological malignancies are available, for which the CAR T cells are either in the clinical trial phase or already they have approved by the FDA for the therapeutic purposes. So in the first column there are the hematological malignancies, and in rows there are the CD markers for which these CAR cells can be developed or already in the therapeutic part. So if you will see here, so these are the CAR cells which are available for the hematological tumors which targets the different proteins. So CD3 epsilon and 41BD is targeting BCMA and reported for multiple myeloma malignancies. So if for AML also CD33 is a target, of CD123 could be a target. So before we go into the details, so there is a process and the workflow is established for which particular patients we have to apply for these CAR T cells, because all the patients won't be eligible to receive this CAR T cell therapy. So let us see how we proceed further. So from the application part of the CAR T cells, it can be applied either for liquid tumors, it can be applied in the cases of solid tumors. Solid tumor, it can be for breast carcinoma, colon carcinoma, for prostate carcinoma, for lung carcinoma. While in the case of liquid tumors, it can be for LL, CML, NHL, or broadly it can be applied for all the type of carcinomas. So now let us see what the pathways, how we can implement the CAR T-cell therapy in the clinical setup. What are the steps? What process we have to follow to implement in a clinical setup? So first step is the patient evaluation and selection. So this is a very key step to implement the CAR T-cell therapy in the clinical setup. So how we select the patients? So the key steps in selection of the patient is the relapse. The patient should be in the relapse or refractory confirmation, the referral to the panel of experts for CAR T-cells, and the application, assessment, and the approval. This is the key step to implement the CAR T treatment. The second is the T-cell extraction. Once we know, we select yes, the patient is eligible to receive the CAR T therapy, then we have a lab process, we have the clinic process, and under that, the first step comes the harvesting of the T-cells. The key steps in the T-cell harvesting is the acquired CD3 plus T-cells, the leukocyte suppression using the apheresis or leukapheresis process, and then the cryopreservation and shipping to the manufacturing facility. So always the manufacturing facility is little away from the clinic. So we have to optimize this process of cryopreservation and how we ship these cryopreserved T-cells back to the manufacturing process. In the lab, so we have to modify these genetically engineering and expansion. So we have to incubate these T-cells with the CAR cells so that the CAR gene can be incorporated in the T-cells for which we have isolated from the patients. So in that process, the first is the activation of the T-cells, then the incorporation of the CAR gene in the T-cells, and then the culture concentrated and the cryopreserved back before we get back to the patient. Then the conditioning therapy and infusion. In this process, the key steps involves pharmacy receipt and the product check, conditioning therapy administered, the patient identity confirmation and product match, and the last step is the again we have to monitor the patient and the recovery of the patient. So the strict discharge plan should be provided to the patients, and the patient should be under monitoring for the late onset of the adverse events and the alternative treatments in the non-responder patients of the CAR T cells.
Eğer aşağıda kırıyorsun varsa kırıyor da kalabilirsin.
So for this, all these steps, there are guidelines and the approved protocols and procedures should be implemented so that all these steps should be monitored closely from the step 1 by the from the harvesting from the patients till we discharge the patient and monitor on a regular basis. So how does CAR T cells work? So this is an overview of the entire process. So first we have the selected patients who is the potential acceptor for the CAR T cells. So we harvest the T cells from the patient using the apheresis. We send these cells to the lab or the manufacturing facility so that these T cells can be genetically engineered and then expand, and then back we can send these cells, genetically modified cells, back to the clinic to infuse back to the patient. So this is the overall workflow.
Katılımcılardan mikrofon ve kamerayı kapatmalarını istiyoruz.
How we monitor the number of T cells, quality of the T cells, enrichment of the T cells, whether the T cells are being genetically modified or not. optimal number of the cells which have to be given back to the patients. So let us see one by one and all the steps how we have to monitor. So the various steps are involved in the CAR T cell therapy. So the first step is the T cell manufacturing. Process verification, scale up and release and the analysis certificate. So we will be discussing all step by step in the subsequent slides. So let us see what are the different methods for TILs. What is TILs? TILs is the tumor infiltrating lymphocytes. So there are different procedures and methods to produce them. So I have shown here the 4 common processes for the TILs production. So in the figure A, it is a very conventional process to produce TILs. So first we take the tumors and just expand in the specific media so that it will express slowly, and then it will express for the specific surface markers like OKT, which are the initiating or the nascent markers for these TILs. And then we go for the formulation and the infusions. The entire process takes more time, 3 to 5 weeks around it takes. So we don't have that much of time to provide a treatment to a patient. So an improvement method has been developed which is listed in the D, C and D. So these process takes less time and more refined process from the process 1. So in all these process, what we do, we harvest the lymphocytes from the patient T cells and enrich only for the specific T cells, like we deplete the other cells like anti-CD4, anti-CD14, anti-CD45, all that we deplete using a specific microbeads, and we enrich the T cells like a CD4 or CD8 we enrich, which is of our target and for which we would like to modify and give the therapy to the patient. Then these enriched cells are incubated with the CAR cells. So first we activate them using a CD28 or CD3 microbeads so that they will activate these T cells, and then these activated T cells are incubated with the CAR cells using a vector. Then these modified CAR cells are expanded in the culture up to the optimal number of the cells and then give back to the patients. Now second part comes the vector. So how we design these vectors? Because we have to first we identify the targets for which we have to produce these CARs. So the identification of targets in the CAR cells is very, very important steps. So there is a steps how you identify abnormal targets for which you would like to give the therapy. So then once we identify the targets, we have the peptides, we have the epitopes design, then we have to use all these in the vectors. So most commonly used vectors are the lentiviral vectors of CAR therapies. So we have the master cell banks. So we have to take the master cell bank, expand it, then all these process we have to follow, and then these peptides can be transfected with these vectors, so that all these epitopes, these targets can be incorporated in these vectors. So now these vectors are ready. So these are the these all process will happen in the GMP cell facility. So once these vectors are ready and we have in our hands, so they are shipped into the hospital lab where our T cells will be ready. So this is again the whole process for these vectors expansion. So they are cryopreserved. We have to retrieve them. So we have to fuse with the our epitopes, peptides into it. then we have to purify it, we have to remove the extra debris from it, and then ultimately we have to cryopreserve them before infusing with the T cells which is harvested from the patient. So when our viral vectors, retrovectors or the lentiviral vectors are ready, so now we need to know whether they are of clinically grade or not. So there are some quality checks which needs to be performed before incubating these CARs with the T cells. So there are few steps and the purity, like a purity check, the safety of these viral vectors, the potency, because they are not potent. If they cannot modify the T cells, then we cannot use the vectors. So these vectors should be active so that your T cells will be modified, so that our T cells will be modified and ready to kill the tumors. And so these are the list of the testing and the platforms how we can perform these testings to ensure that yes, our lentiviral vectors or retroviral vectors are of clinically grade. Because every time we have to check that our T cells should be of clinical grade, our vectors should be of clinical grades, the entire process should be of clinical grade. So this is the clinical grade. So now we have the vehicles to incorporate these epitopes or peptides into the lentiviral vectors. So we have the plasmid. So even our plasmid should be of the clinical grade. So for that also we have a quality control process which should be performed before releasing them. So we have to check the purity, so their identity, the safety and others. So here I have listed the overall view of the CAR T cell manufacturing process. How we have to manufacture these CAR Ts. So it can be divided into two parts, hospital and the manufacturing facility. In the hospital, the first step is the eligibility of the patients, then the pre-assessment, how we do, whether the blood testings or any genetic testing or the tumor testing, that means, so we have to evaluate through all those parameters and the testings for the patient eligibility. Then the leukapheresis is being performed, and once the leukapheresis is being done, so this is transferred to the manufacturing facility. Here the T cells and the CAR cells are incubated together and produce the CAR cells, and then the beads are removed and only the CAR T cells are again shipped back to the hospital facility to give back to the patient. So again, there is a manufacturing phase. So before the manufacturing, there is a criteria for it. So the T cell selection and the activation. So these are the components for which we have to select. Then the genetic modification, T cell expansion, formulation. Under the formulation, once our CAR T cells are ready, we have to wash them. We have to put in some buffer so that it can go back to the patient. The cryopreservation, if immediately we are not giving back to the patients. So these CAR cells also need to be checked for the quality before infused back to the patients. So there are several parameters, quality check from the lab side, from a microbiologist point, because we have to check for the sterility, for their purity, for their identity and for their potency. So I have listed some parameters for which a routine testing is performed for the CAR cells. So these are for the microbiology point of view, sterility testing, gram positive, gram negative, mycoplasma, copies for transgene insertions, CD3 T cells. So all these things also can be done using the flow cytometry. So here I have listed the CAR T cell therapies which also can be incorporated if the hematopoietic stem cell transplantation is happening. So in case of CLL, CD19 is the target, and before allo-HCT it can be given so that the patient not relapse. So CD19 could relapse allo-HCT, CAR T cells relapse post allo-HCT. So these are the some list which I have provided you. for which these CAR T cells can be provided along with the hematopoietic stem cells transplantations. So now these CAR T cells, yes, it's a good therapeutic options when the patient is in the remission and refractory, not responding to any treatment. But this CAR T cell therapy is also having some of the drawbacks, specifically the toxicity, cytokine release syndrome, neurological toxicity, B cell aplasia, tumor lysis syndrome, anaphylaxis. So what do we mean? So when the tumor cells also disrupt, so they release some metabolites, right? So those metabolites also can metabolic syndrome. So that is a tumor lysis syndrome. We have to keep monitoring under that, and this can be achieved by the signs and symptoms of the monitoring of the patients. So in this CRS syndrome, that is which is a cytokine release syndrome, we have to monitor for the fever, myalgia, hypertension, hypoxia, potential organ failures. These are the symptoms for cytokine release. Neurotoxicity, if the patient showed the symptoms of confusion, dynamo, hallucinations, so those symptoms we have to monitor. So these symptoms may be early or as soon as the patient receives the therapy, or they can be a late onset of reactions. But these needs to be investigation and monitor till it achieves the normal conditions. So now in the oncology setting, in the clinical setting, once we have given these cells back to or transfuse these cells back to the patients, so there is a monitoring, as I mentioned in the previous slides. So that toxicity needs to be monitored properly. All these CRS, SLS, TLS, all these syndromes needs to be monitored. So there is a specific role for the nurses who are working in the clinical settings to monitor till the patient gets discharged. So here I have mentioned all these roles and responsibilities of the clinical nurses which are working with the patients very closely. So they have to collect the data, they have to expedite the eligibility screening for CAR trial candidates, communication with the patients and the team. They should provide the education to the patients, the treatment process and the safety management. They should establish the patient care plan based on the established guidelines and manage the patients. They should closely monitor the patients for all these symptoms and promptly respond for toxicities, CAR T cell toxicities and their management. So here I would like to discuss some of the case studies for which already the CAR T cells have been approved by FDA, and for few are still under phase 1, phase 2 clinical trials. For few already the trials are over, but the reports have been awaiting for them. So in case of ALL, CD19 therapy is already limited, and CTL019. These are the CAR cells which have been developed by Novartis in the year 1989, and it is FDA approved for the ALL refractory patients. Patient's age should be less than 25 with B cell precursor ALL, refractory or in second or later relapse. While KT019 and JCARO17 are in the phase 1 and phase 2 trial. So other than this CD19 therapy for the CAR cells is not available for ALL. This is the only therapy which has been approved so far for this treatment. While in case of myeloma, all these antibodies or CAR cells are under phase 1 or phase 2 of clinical trials. While anti-CD19 targeted CAR T cells therapy have been approved for B cell lymphomas and two CD19 CAR T cells have been approved for FDA, while JCAR is under the consideration of the therapy. So this is a very important clinical case, and for the novel conditioning line, which is induced anti-leukemic activity and myeloablation. How we can integrate CAR T cell therapy along with the graftment. So I have discussed all T cell therapies, what are the T cells, how we can harvest, what are the CAR cells, how we have to identify the identification of targets. But so far, so these still the applications are limited, treatments are limited. Why it is like that? Why it is so limited? So there are many constraints. So the manufacturing facilities are not, they are very limited. They are not so many. The accessibility of to these therapies to the patients are limited. The process are not well validated. The issues with the safety, efficacies, and the creation of the novel targets. So these are the limitations which makes the limited use of CAR T cells. So in the future, so far only CD19, CD20 are approved for leukemia. But what about for solid tumors? What about for other cancers like AML, CLL and other things? So there is a future for this creation of the CAR T cells. So first is that we have to identify more novel CAR targets, so that these targets, so that these cells can be developed. As we have seen in the previous slides, we are identifying or the isolating T cells from the patients itself. So this makes the limitations for us. So if we can identify the donors of these T cells, where we can keep and store these manufactured CAR T cells, so that can be an option, so that immediately we identify patients and we can use those CAR T cells. So the safety, so the biggest issue for these CAR T cells is the toxicity. So 50% of the patients show early or late onset of the toxicity. So if we have to work towards increasing the safety of the CAR T cells therapy. So manufacturing process, we have to build more and more manufacturing facilities within the hospital or within the near vicinity of the hospitals for more use. And so that these CAR T cells therapy can be more accessible to the patient. So even the challenges are, so for currently available CAR T cell, again the challenge is there, for the biological challenges are there. So what I have discussed, these are the manufacturing challenges, but there are more biological challenges are also there. The on-target, off-target toxicities. So as I have mentioned, the on-target toxicities are there for the CAR cells. But what about the targets? Because when we give them, other cells will also produce cytokines. What about those toxicity? Antigen escape. So some antigens, so these CAR cells are specific to one antigen. So if these antigens will find out the way to escape, then these CAR cells will not work. So all these issues we have to address, and these are the future challenges where we have to concentrate and refine this therapy, and which can be usable for the patients. These are the many companies are available which are either working on the CAR cell therapies and already providing the CAR cells, like Novartis is one, Amgen is one, Pfizer is one. So these are the companies which working towards the betterment of the production of CAR T cells. Still that is still the CARs. So that whole entire process takes 3 to 4 weeks. So isolation of the T cells, then incorporation of the CAR genes, then again culture, expansion, that whole process takes 3 to 4 weeks minimum. Why it takes so much of time? Because these we have to construct these vectors or the CAR genes specific to the patients. So once we identify all the targets, we have all these scars in our head. So once we have these scars in our head, so probably we can limit the time of the production of these CAR T cells. So I would like to conclude my presentation here with the points that the CAR T cells have emerged as a powerful new class of therapeutics and have marked the beginning of a new era in the cancer immunotherapy. Over the decades, with the advancement both in the basic and the translational research which have contributed in the development of the first personalized medicines to find out the targeted therapy. To date, the progress in the CAR cell field has offered a new hope for the terminally ill patients where we do not have the hope for improvement using the conventional therapies. The future developments will certainly improve the safety and the efficacy of the CAR cells and which should be specific to the cancer types, especially the field of the solid oncology. Finally, a significant reduction in the manufacturing cost. So as on today, the manufacturing cost is huge. One time patient, they have to spend around 500,000 USD for one time treatment. So if they relapse in the first time or if we have to give another second time this therapy, they have to spend the same amount of the money. So we look forward the reduction on the cost of the manufacturing of these CAR T cells when the more industrialization and the improvement in the manufacturing guidelines and facilities will come up. In this context, the development of universal CAR T cells that are produced from the healthy donor cells, subjects of the shelf product might mitigate the cost and shorten the time span until patient can get the potentially life-saving cells. So as I have mentioned that at present we take the T cells from patient itself. So if we have come up with this strategy, which these CAR T cells might become as a universal T cells, so that we have healthy donors to produce these CAR T cells, which can be store and manufacture them in advance, and then as per the patients we can give them back. So this will reduce the cost and the shelf life and the time period to save the patients. So with this message, I would like to conclude my presentation here.
Okay,
if anyone has the question and answer, we can go for the Q&A.
Again.
So, Mittal, can you hear me? I think there is still problem. Mittal, thank you very much. Can you hear me? Şey üzerinden bağlanalım yine. Dr. Mittal, thank you ever so much.
Thank you, sir.
I think that we cannot solve it out the problem, but just I am going to ask the audience, is there any problem? I can carry the questions to you.
Yes.
Just I am going to ask somebody who is just participating in this conference. DELL, the computer name. If somebody who has this one, the microphone.
Yeah.
Anyway. So can you hear me now?
Yes, I can hear.
Okay. just taking the opportunity,
Yeah.
I would like to ask that.
So this
Yeah, you can ask, sir.
okay, CAR T cells, especially you are using the vectors. All of them are just confined to a few viral vectors, as far as I have understood. Okay.
Sir, you have to keep your phone on, then only I will...
Yes, without phone it is going to be
Just
impossible
keep your
to connect.
phone on.
Yeah. Okay, it is on now. Just Mittal, I would like to ask that you have already mentioned that the producing of the CAR T cell, the viral vector is necessary, but the vectors you have already been shown that a few. So do you think that all of them just confined to this virus? Is there any more?
There are many more actually, so this is only the lentiviral and the retroviral vectors. There are many more vectors.
Okay. And also in our audience there is a physician from urology department and general surgery department. They possibly asking that is there any CAR T cell treatment for prostate cancer and breast cancer?
Sorry? Can you repeat your question?
Now, I am asking that generally CAR T cells are used for hematologic malignancies. Besides this, is there any clinical, the trial for the breast cancer or the prostate cancer?
Yes. For solid tumor, most of the solid tumors, these are under clinical phase 1, phase 2 trials. So some have passed, reached to the second phase and the third phase trial.
Okay. It was now.
So I can share at least the entire list with you, where all these diseases are listed, all these trials, their number, and for which target they are.
Okay, it will be very nice. So if there is no, and the final one, after using these CAR T cells, especially cytokine storm, do you think that in future these sort of pathologies could be hampered by using their special treatments? Oh, okay. Okay. Yeah, now I've understood item. Okay. Okay. Thank you ever so much. Now.
So those criteria are very, very important.
Okay. So. I would like to just end off this talk in here. Thank you ever so much, Mittal, for just contributing.
Thank you so much.
So, from Izmir now, it is quite sunny and nice tea. In behalf of all my colleagues, I would like to thank you to hosting you in here. Okay, I'll carry these matches to the audience. Thank you so much.
Sure.
Okay, bye-bye.
Thank you so much.
Nereden şey yapıyoruz?
Arkadaşlar, teşekkür ediyoruz bağlanan şeylere. Bunlar Novartis için Özellikle akut lenfoblastik lösemiler için Cartesian üretiyorlar. İngiltere'deki hastalar için GMP standartlarında yerleri var Hindistan'da. Bizim de Sayın Başhekim Bey'le de konuştuğumuz ileride Türkiye'de bu Cartesian üreten veya bununla ilgili çalışan 2 tane özel hastane var. Onların uyguladıkları tedavi şekilleri var. Başarılı olduklarını söylüyorlar. Çok fazla vaka yok. Ama gelecekte bu tedavi çok önemli bir yer kazanacak. Biz de bu konuyu hem haberdar etme, zaten hepinizin bildiği şey, fakat biraz daha detaylı haberdar etme adına bu toplantılara devam edeceğiz. Bu o üretim safhasında Hindistan'daki GMP standartlarında İngilizlerin koordine ettiği standartta çalışan birisi. Moshe diye İsrail'den, aynı zamanda HLA'da çalışıyor. Sanderson İngiltere'den, King's College'den. Bunlarda da ileriki dönemlerde bağlantı kuracağız. Belki kabul ederlerse üretim fasilitelerini dışarıdan çekimle görmüş olacağız. Bütün bunları yapmamızın sebebi aşağı yukarı bunu klinikte kullanacak arkadaşlar artı böyle bir yatırımın İzmir'de yapılması, Türkiye'de yatırım yapılması ile ilgili biz Tepecik grubu olarak öncü olabilir miyiz? Bunun gayreti içindeyiz. Umarım bunu başarırız. Bunu başarırsak gelecekte bu hücresel tedaviler inanıyorum ki rejeneratif tıpta ve çok önemli bir yer alacak. Katıldığınız için çok teşekkür ediyorum. Ben bu bahsettiğim 3 isimle İsrail, İngiltere ve Hindistan'daki bu grupla irtibatlarım çok iyi. Tanıdığım